Visible?
Yes, sir.
Okay. So two aspects of geriatric hip fractures make it challenging to follow other common pathways that are usually done for that. First is the timing of presentation. Patient presents most of them with a hip fracture, which is a very acute condition. So in an effort to decrease morbidity and mortality, the recommendation now by majority of the people doing orthopedic work is the optimal time is the fracture should be fixed within 24 to 48 hours. So the lack of time prior to surgery, if it is a elective hip arthroplasty, for example, you do it for rheumatoid arthritis, there you have plenty of time. But if a patient comes with a fractured hip in an acutely painful state, then the time for doing ERAS protocol is very much restricted. So the lack of time prior to surgery is often the main difficulty in applying the common that is enhanced recovery ERP principles such as full optimization of medical conditions and nutrition, encouraging the consumption of clear fluids and all this which are usually practiced, and fully educating the patient and their families and setting comprehensive post-op expectations. So vast majority of patients, again the second factor is they are older patients, geriatrics, and this population has got increased comorbidities. So that is the reason why not all of them will be fit for the ERP protocol or the ERAS protocol with hip fracture. And physiological changes related to aging is also there, and efforts to reduce polypharmacy and delirium are very essential. You would have seen some patients, elderly patients, who come with fractured neck of femur, and with severe pain, they become delirious because of the pain itself. So these patients may not be the ideal candidates to plan for a ERP or ERS protocol, and the pathway is automatically initiated once the fracture is diagnosed radiographically in the emergency department, and consultant orthopedic surgeon feels that it is operable, then the ERAS protocol launches and cascade of events are initiated in the ED department itself. This is a very, very important point you should remember. So it is easy to practice ERAS protocols in elective hip arthroplasty done for indications other than fracture. This is a very valid practical point that you should remember. Now the overall guidelines, this flowchart gives you how to think about or write your answer for arthroplasty. The first and foremost is patient selection. I am very sorry for the very hazy letters that you are seeing here, because if I try to expand this, it becomes more hazier. So I will just try to read out who are all the patients. This patient selection tells you the patients who are not fit for ERAS protocol. So if the patient does not have a caregiver or an attendant, or the patient has got some other handicaps like hard of hearing or visual impairment, or he lives in a place which is travel time is more than 60 minutes from the hospital, or the patient has got communication or cognitive problems, and there is a need for long-term urinary catheter after surgery. For example, a patient with an enlarged prostate who has already been having symptoms of BHP, and this patient may require urinary catheter so after surgery because he may not be able to void. And patients who have coagulation difficulty and or who are already, for example, elderly patients with atrial fibrillation may be on warfarin for a long time, or they may be on oral anticoagulants. And the patients with systemic disorders which require specific preoperative care, like patients who are on dialysis or patients who are on cardiac monitoring, like pacemaker or implantable cardio defibrillator. These are all the patients who are not ideal candidates for ERAS. So we must exclude all these patients and select patients who do not have that much of severe comorbidity or coagulation difficulty and fairly acceptable levels of hepatic, renal, cardiac, and respiratory functions. So that forms the first and foremost criteria for hip arthroplasty. This point you should mention about patient selection. Even if you are not able to write all the detailed contraindications, you must give at least a few of these contraindications to exclude the patients who are not fit for ERAS protocol. Then once you decide the patient is fit, as I said earlier, in acute conditions, the pain relief is the first and foremost thing which should be started in the emergency department itself. Then coming to the patient education forms the foremost thing in ERAS protocol. So you must talk to the patient, talk to the relatives, and explain all about the ERAS protocol, what is expected out of them, and what you are going to do, and how the patient is going to experience the various things. And if the patient is a smoker or alcoholic, you must ask them to cut down all that, and identification of risk factors influencing the protocol, and rehabilitation exercises should be started. So you must start with the physiotherapist help. And if the patient is taking drugs on a chronic basis, like for hypertension, diabetes, asthma, all those drugs, you must plan whether you can continue with those drugs or stop them. Then whatever modifiable risks are there, like anemia, diabetes, ischemic heart disease, sleep apnea, venous efficiency, dental problem, or whatever modifiable risk we can correct to some extent. We said, for example, you should achieve a good glycemic control quickly. If the patient injury itself will increase the blood sugar value, but if the previous HbA1c is normal or within acceptable limit, we need not worry about the transient hyperglycemia which the patient may be experiencing because of the pain. So all that we should take into account, and in the nutritional status also we have to take into account obesity. All these factors we have to take into account and try to do the maximum optimization. On the day of operation, what are all the things we have to do? You do the limited fasting protocol. As she rightly mentioned, we can give clear fluids up to 2 hours, and patient can take 20 ounces of clear fluids like water, tender coconut water, or Gatorade up to 2 hours of surgery. And there should be a chlorhexidine wash should be given the previous day and on the day of surgery. The skin preparation is very, very important. You should not use a razor and try to remove the hair. That is now not accepted. So a chlorhexidine wash, there is a commercial preparation called lyso wash, with which the patient can be given a sponge bath if he is not able to ambulate, in the bed itself, and prepare the area also where you have to put the incision with this chlorhexidine preparation. And preemptive medications like long-acting acetaminophen or gabapentin, NSAIDs, dexamethasone, all these things can be given. And you can start tranexamic acid preoperatively itself before the incision is put, and then nowadays they recommend 1 dose prior to the incision, 1 dose 2 hours after incision, and 1 dose in the post-op. That is the regimen that is advocated for tranexamic acid. Antibiotic prophylaxis is very important, and as far as possible, opioid-free and benzodiazepine-free anesthesia to be made with limited motor blockade. This is very, very important for ERAS protocol, because we want to ambulate the patient as much as possible. So even if surgeon also should understand that if you are planning for ERAS, you cannot get that much of muscle relaxation like what you get with a dense spinal. So the surgeon also should know how to operate with a limited motor blockade. And for that, they use what is called the local anesthetic infiltration. Is that what is being recommended currently, where you can use 200 cc of saline with 400 milligrams of ropivacaine and Toradol and adrenaline. So infiltration with adrenaline and local anesthetic is considered a very great boon in all joint replacement for post-op pain relief without motor blockade. And avoid as far as possible urinary catheter and drains in the wound also. The surgeon should know that he cannot put a drain as a routine. Avoid tourniquet and avoid continuous nerve block. Vidya, you mentioned about continuous epidural. This is not recommended for ERAS protocol because we want the patient to ambulate as quickly as possible, and wound closure with subcuticular or a glue is more recommended. Then post-op, of course, you do multimodal pain control, early mobilization, and no range of movement restriction, and early feeding and thromboprophylaxis is recommended. Okay? So we have to remember that analgesia begins in the ED, and the common block that is given is an ultrasound guided single fascial block, which is done either by the emergency physician or anesthesiologist from acute pain service. And this is also called the on-arrival block since it is administered very early in the patient. Now quickly I will go through some of the points that have been given in that flow diagram. The first thing, after you select the patient and family engagement is very, very important. So you can talk about smoking cessation, alcohol, and early physiotherapy, discussion about pain management, and patients' drugs should be documented and identify people sometimes may be opioid tolerant or benzodiazepine tolerant because they use those drugs in a chronic fashion. So that can be identified by talking to the patient, and then they may need additional counseling and psychological services. And we must also talk about the logistical issues of patient transport and home care, because we are going to discharge the patient within 24 to 48 hours because of rapid recovery. You must know that somebody can take care of the patient at home and how you are going to transport them. Not that all the patients will walk and be able to climb the steps immediately after 24 hours. So that all the logistics also should be thought about. Then comes the patient optimization. So again, you have to know whether they are addicted to alcohol or smoking and whether any comorbidities require any attention. And patients with prostatitis symptoms should be identified because they may require oral tamsulosin because they are all elderly and they may go in for urinary retention. So in elective cases, we can start this 3 nights before hospital administration, or in acute cases, you can at least give one dose as early as possible. And venous insufficiency in chronic lower limb swelling must be treated with compressive stockings pre and post-operatively. Non-modifiable conditions are renal insufficiency, so you must restrict the use of NSAIDs in those patients. And some drugs may be discontinued. For example, AC inhibitors, normally we discontinue. Some drugs may be resumed as early as possible in the post-op phase. Then infection prevention. So patients who stop smoking or alcohol consumption or a good diabetic control and anemia, these are all preoperative preparations which reduce the risk of infection. And 4% aqueous chlorhexidine gluconate wash in the morning of surgery. And shaving should be avoided because it will cause microabrasions and it will allow the bacteria to grow. And you have to give antibiotic prophylaxis. First or second generation cephalosporins are the ones which are recommended, either cefazolin or cefuroxime, and it should be IV only, 30 to 60 minutes before incision as a single weight adjusted dose. And coming to blood conservation, it may cause substantial perioperative blood loss. So that can be minimized by either good hemoglobin optimization, systemic tranexamic acid, and the surgeon should take care of hemostasis properly, and use of adrenaline in local anesthetic infiltration also helps in blood conservation. And maintaining high post-op hemoglobin will improve patient recovery and reduce the risk of ischemic cardiac events also. So post-op hemoglobin can be checked now at bedside with a, what is the point of care testing for hemoglobin? Any idea? It's called HemoQ. Okay, so there is an instrument just like your TEG. You have a HemoQ with which you can assess the hemoglobin in the bedside itself. And pain control is by multimodal approach. So you can use acetaminophen. So paracetamol is our mainstay, and you can use NSAIDs if renal function is all right. Dexamethasone, a long-acting opioid, should be uh, used carefully, and pregabalin is also recommended. And intraoperative anesthesia can be a combined epidural with xylocaine, not any long-acting. And to tolerate the position, which is usually the lateral position, you can do a sedation with propofol infusion, or you can give a short-acting spinal with the fluoropropane and periarticular tissue infiltration. Nowadays we talk about PENG block, PENG pen block. I think all of you would have heard about it and read about it. So that also can be used with large doses of local anesthetic, which will minimize the post-operative pain. After surgery, you can use cryotherapy also, along with the other drugs that you use, and early mobilization. So ERA's main thing, just like early pain relief mobilization is another important factor in ERA's protocol. So minimize the risk of orthostatic hypotension or urinary retention, and limit motor function loss after surgery. So we should not continue with epidural with a higher concentration, which may limit the motor block. So nowadays we go for selective sensory block with sparing the motor nerves, so that patient can ambulate easily. Catheterization and wound drain should be avoided, and you can use preoperative dexamethasone 6 to 10 milligram, 10 milligram IV, and opioid-free combined spinal epidural sedation to avoid complete motor block, which can allow the patient to move their feet even during the surgery procedure, and allow patients to stand and walk within 2 to 3 hours of surgery. And by adopting this multimodal technique, the regulation of cortisol and adrenocortical hormone levels is better maintained. So the range of motion, weight-bearing restrictions should be avoided to facilitate early mobilization. Coming to gastrointestinal function, post-op nausea and vomiting is a very important thing which should be taken care of. So we can take care by a combination of various things like preventing hypovolemia, prolonged preoperative fasting, anemia. All these things will opioid use should be avoided. By you can give clear liquids up to 2 hours before surgery, and anti-nausea prophylaxis is a combination of earlier we were talking about ondansetron and dexamethasone, but now the preferred drug is apriprazole, which is a later generation of I think it's a neurokinin 1 receptor blocker rather than H2 receptor. Is that
Serotonin antagonist.
yes. And scopolamine patch is also advocated. And so this is the epitan, which is a lipophilus powder which has to be dissolved, and 150 milligram can be given. And this is a transdermal scopolamine patch, which is usually stuck behind the ear like this, and that has a good antiemetic property. And patients are encouraged to eat soon after surgery to promote gastrointestinal function. And the prevention of constipation also is very, very important in the elderly. So apart from your nausea prophylaxis, you can give this Duflax syrup for preventing constipation also. So people feel happy if they pass motion within the second or third day. And prevention of thromboembolic, you can go for PVT. Usually it happens within the first starts happening at the first 24 hours. So intermittent compression stocking, early mobilization, and oral anticoagulation therapy. And you can give low dose aspirin preoperatively. It is not contraindicated. So even if you plan for any central neuraxial blockade, low dose aspirin is not a contraindication. So 80 to 100 milligram can be given. And coming to wound management, one optimized method of sealing the skin is subcuticular skin closure or skin glue. and this seals the wound and prevents discharge or retrograde contamination. Avoid staples as much as possible because it will hinder with resuming the bathing also. So the subcutaneous stitch or the skin glue allows the patient to take a bath immediately after surgery. For the benefit of those who have not seen skin glue, this is how it is applied. It is just like a viscous solution. It is applied, and once you bring the skin edges closer and put this, it will get automatically sealed. And the commercial name is Dermabond, and it comes in a small collapsible tube, and you can just apply it over that. And there is another one called the cyanoacrylate glue, which can be loaded in the syringe and then used. So this is a summary of quick revision for you to remember this. We have this thing. So preoperative, first thing is pain management with a fascial block, and you can use very low concentration of bupivacaine and then minimize opioids. Then go for anesthesia notification and coordination. So go for pre-anesthetic evaluation testing and do some minimal requirements of blood testing, and then anticoagulation. If you have if the patient is already on warfarin or coumadin, hold that. The INR should be less than 2 and consider reversal if it is more than 2. And the NPO guidelines, you have no solid for 6 hours, clear liquids of 20 ounces until 2 hours free of, and you can give that electrolyte drinks or water, and the delirium prophylaxis also. So avoid benzodiazepines, especially if the patient is in pain and you have not given the block. Giving benzodiazepine will be a disaster in old age people. And avoid anticholinergic, antihistaminic, and antipsychotic. And free of multidosal anesthesia, the paracetamol, COX inhibitor, and block can be repeated if it is more than 18 hours. So these are all the pre-op preparation. Intra-op, you have to do first infection control, thromboprophylaxis, and between neuraxial and GA, neuraxial is the preferred technique. And if GA, you can mix anesthetic or use TBAR with a short-acting drugs and reverse with Sugammadex if you are using rocuronium. Then monitoring, the standard ASA monitoring, and there is no need for any subcutaneous catheter. 2 peripheral IV lines may be required. Arterial line may be indicated if there is any cardiac issues. And post-op prophylaxis, PNOV prophylaxis is dexamethasone, ondansetron. Fluids, of course, you give according to the requirement. And again, another important insistence is pain management using ketorolac, acetaminophen, and avoid long-acting opioids and dexmedetomidine for these cases. Consider ketamine if the patient is opioid tolerant. That the patient has got history of opioid addiction, then ketamine low dose infusion will be the ideal post-op drug. And for prevention of blood loss, you can use tranexamic acid, 20 milligram per kg, up to 1 gram IV per incision, possibly second dose at the end of the case per surgeon request. And sometimes cell saver also can be used. Post-op, again, pain control, nausea control, fluids, and early oral intake, and resumption of oral intake as early as possible. So this is what you have to write for this particular question.